Aloha all, and thank you for joining in the Caregiver Foundation's monthly caregiver support group. And it's our pleasure to welcome Kokua Mao and our guest speaker, Hope Young, who is the Advanced Care Planning Coordinator with Kokua Mao. And let's see, Hope will offer some information about Kokua Mao, but it's an organization that fosters meaningful, thoughtful, and sensitive conversations on improving care and support for those with serious illness. So, thank you, Hope, for joining us today, and we'll turn the microphone over to you.
Thanks. Let me share my slides. All right. So Happy New Year to you all. I'm sure you're getting into the swing of doing things. Of course, it was a nice holiday weekend, but thank you for inviting me to speak with you. My name is Hope Young, and I am from Kokua Mao. And who we are as an organization, we are a statewide coalition committed to improving care for people with serious illness. We are a community benefit organization. We are not for profit. And we are supported through members. Our members include organizations like health plans, hospitals, hospices, long-term care agencies, long-term care uh, residences for seniors. We have very different, a bunch of supporters that see the work that we do. We also have members that are churches and temples, as well as individuals. And through their membership, they support Kokua Mao and the work that we do out in the community. I get the joy of working with passionate volunteers across the state. My volunteers include retired nurses, social workers. I have a couple of doctors and some committed individuals who have seen the work that can be healthy for families. So we want to make sure that we acknowledge them. And we concentrate on the continuum of care through advanced care planning, um, post, advanced directives, palliative care, and hospice and bereavement. We talk about all of those things in the space that we are in. So our three areas of activity is that we work with people who may be facing serious illness and their loved ones to understand the decisions they may need to make as early as possible. So I like to be a little bit interactive. So I'm going to ask you out there, we're going to pause, and has anybody thought about how they want to die? Yeah? Okay. Let me guess. Quick, or in your sleep, hopefully with no long drawn out illness. Sound about right? Okay. These, for average, so you know, only 10% of the population goes out like that. So the rest of us, 90%, we may be facing serious illness. So this is one of the people that we want to be supporting in the work that we do. We also provide professional networking and training, and then we do a little dabbling in policy. We like to think of Kokua Mao as a movement for change. We are leading a movement to make advanced care planning and these conversations about care and support for those with serious illness. We want to make this a cultural norm. We want to get people back to having these conversations around the kitchen table again. So how do we do that? Well, we do like humor. So if you are on a phone or a device where you can't see the font, I'm just going to read this to you. Communicating with dead people is easy, but communicating with live people is hard. Would you agree? Yeah. So we're going to be talking about advanced care planning in general, but also about the documents that support your wishes for care. So what exactly is advanced care planning? It's an ongoing process of thinking about, talking about, writing down, and sharing your healthcare wishes. This is the big picture of what part of where advanced directives fit in. And just so you know, I never want to live in a vegetative state dependent on some machine. If that ever happens, just unplug me. I'll give you a minute. So, okay, there, I caught some smiles. She is unplugging him. This is not effective advanced care planning, by the way. So, how we've thought about how you want to die. If you've thought about where you want to die, hands, anybody thought about where? As a caregiver, you may have this thought on your mind about the person you are caring for, But it's also important to recognize that you need to do this work for yourself as well, because someone one day may be your caregiver as well. So I encourage you to have these conversations about where would you want to die. 70% of people say that they want to die in their own bed. They want to die at home, surrounded by their loved ones. However, 70% are still dying in a hospital setting. So there's some sort of disconnect, right? There's something is not happening for people to get what they want. 80% of people want to have these conversations with their doctors. They want to talk about the scary stuff. But in Massachusetts, only 17% of people actually did. In our California cousins, only 7% of those people actually did. But 90% of people think that these are conversations that are important to be had. Here in Hawaii, a few years ago, we did do a survey, a phone survey, and 30% of people here in Hawaii are reporting that they are having these conversations. But that means there's still room for improvement as far as having more conversations. So again, advanced care planning. What is it? It's talking about, it's thinking about, writing down and sharing your healthcare wishes and why it's so important. Who's planning on getting dementia? Anyone planning on getting dementia? Nobody ever plans for getting dementia, right? It's just something that kind of happens. But it's important to recognize that people may become very ill quickly. And having this information in place can really help the caregivers. I don't know if any of you have had this information available for you to help you with your decision making for the people you care for. But imagine if you did, if you don't have it now. Imagine how different your world of caregiving experiences would be if you actually were on the same page as the person you're caring for. This is really an opportunity to help your loved ones to find your voice if you're unable to speak for yourself. It helps to ensure that your wishes are known and honored. And it also goes to say that there is no next of kin rule in Hawaii. What that means is just because you're married doesn't mean the next of kin is your spouse. Here in Hawaii, we have a different approach when we try and figure out who's next in charge for someone who hasn't named their agent. Briefly, it is they will bring everybody together and say, who's in charge? I'll go more into that in just a bit, but I just want you to keep that in your mind that it doesn't have an automatic next of kin. So, oh, missed a picture. Sorry. If the unexpected happened, who would speak for you? And would they know what you want or possibly what you don't want? How would they know? The only way that they would know is if you have these conversations with them and document advance directive. It does a few things and it's intended to help your loved ones find your voice when you're unable to speak for yourself, right? So it names your healthcare power of attorney and it gives that person kind of a roadmap on making decisions on your behalf if you're unable to do it for yourself. This is something that's not a one and done document, so it should be reviewed and followed up with it and made sure that it's still up to date on a regular basis. So who actually needs an advance directive? When I first started in this field, Kupuna would always come back to me and say, "I'm not old enough for that." Well, we had to change the bar for that. Everyone over the age of 18 should have an advance directive. Every competent adult should have an advance directive to at least name their healthcare agent. Without that advance directive, again, we have to figure out who's in charge, right? They're going to bring all the loved ones together. And imagine if you have a big family, bringing all the loved ones together and say, loved ones, who's in charge? Some families, it's very easy to figure that out. In other families, there are many opinions and there are many vocal opinions. So rather than having your loved ones try to figure out who's in charge, why not do this for them? Give them the gift so that they don't have to try and figure out who's in charge. You've already decided for yourself who you trust to make those decisions. If your loved ones are unable to come to an agreement on who's in charge, we could be looking at a guardianship case. And Gary, I'm sure those are something that you're familiar with as far as guardianship goes, but it can take quite a while. It can take 18 months to 2 years, um, thousands of dollars, and it can be kind of stressful. Again, this visual is very helpful, especially with my kupuna when I go and talk to them. They are all excited about having their estate plan done and their will done, and they are so happy they have their funeral arrangements made and all of that fun stuff. But I like to point out to the other side of this that this is just good planning. This is helping your loved ones. This is helping your caregivers. This is helping you to think about it ahead of time. So it is under health, but I also think it's a part of legal and personal um, planning. So why is this document so important? Well, first of all, it's naming your agent, right? It's naming the person you choose to trust when you cannot speak for yourself. If you need to download one of these, please, by all means, our website have them for free. If you do go to a lawyer to do your estate planning, they may offer to do an advance directive with you. If you'd like to save yourself a few $100s, just go ahead and do it yourself. What is this document? Well, it's a legal document that can be completed when you are of sound mind. If there's any questions of capacity or if the person is showing signs of dementia, it could be questioned whether or not they were influenced in any way with the decisions that they make on their document. So the first part of this document appoints your healthcare power of attorney. We also call that your agent. This is your person that you trust to make your decisions on your behalf if you're unable to make them yourself. And then it gives instructions for your future choices on end of life decisions. So the first section is choosing that agent. Who do you trust to make healthcare decisions for you when you are unable to? This is someone who should be familiar with your personal values. This is somebody who needs to be comfortable with willing and able to make decisions. It does not need to be a family member. And you want to select a second person. If you automatically default to a certain person and you think, oh, yeah, that's who I would choose to be my agent, you really want to make sure you have a conversation with them so that they know that they've been asked to be the agent and also so that they are comfortable in making decisions on your behalf. Don't surprise people and just put a name down and don't have a conversation with them, because when it comes time for them to step into that role, it's not very helpful, right? So you want to make sure you have that conversation. The reason we ask you to select an alternate is so that if you're in the car with that person and you get into a car accident, you want to have a secondary person who's able to step into that role. I've had people say, can I have all four of my kids be my healthcare power of attorney? Technically, you can. Would I recommend that? Not necessarily, because now that means four people have to all agree on what the next steps of care are. Usually, the one caregiver who knows the background, who's been doing the caring for the individual, that's usually the person that you want to have step into that role if they're able to. That's the person who knows that individual best. They probably had lots of conversations. So think of this with two different hats on. Who do I choose for myself? And the person I'm caring for, if they still have capacity, let's have a conversation with who do they trust? Because it might not necessarily default to the person who's providing the caregiver, um, the caregiving. Sometimes they might say, well, no, I know you know everything, but I don't want to stress you out in this point in time. So I'm going to ask my sister to be that person. Okay, now you've had a conversation to figure that out, right? Next part is, when does a document come into play? So it has certain circumstances. And if I have an incurable or irreversible condition that would result in my death within a relatively short time, or I've lost the ability to communicate my wishes, or if the likely risks and burdens of treatment would outweigh the expected benefits. This is when these documents come into play. However, if you are doing a document with someone who still has capacity and who wants you to be involved with the caregiving decision making and healthcare decisions, there is also a box that says this person has authority immediately. So you can check that box and you would be immediately put into that role of a healthcare power of attorney, the healthcare agent. What that does is that gives you the authority to call the doctor's office and ask questions on mom's behalf. It gives you the opportunity to have these open conversations with providers so that they are able to release information with you, even if the person you're caring for is not with you. So there is an opportunity for you to have that done as well. Now, this one, I like to kind of spell it out because the first thing they're asking you, besides who's your agent, is would you like to prolong or not prolong life? So the choices are I want to stop or hold medical treatment that would prolong my life, or I want medical treatment that would prolong my life as long as possible within the limits of generally accepted healthcare standards. That's a lot to say, but what does it mean? So the first choice, I want to stop or hold medical treatment that would prolong my life. This is usually somebody who does not want to be in a hospital. This is somebody who maybe already has a diagnosis or terminal illness, and they know that this is the course of action that is heading their way. They know they are progressing, and they'd rather be at home. This is also somebody who's very adamant that they do not want CPR. They probably don't want medical intervention. They don't want any additional things that would prolong their life. The second one is that I want medical treatment that would prolong my life as long as possible. This is somebody who's saying, take me to the hospital. Let's see what they can do for me. This is somebody who recognizes that generally accepted healthcare standards could be being in an ICU. That is something that's possible when you say, I want medical treatment that would prolong my life. Keep in mind, we've come so far in the medical field that we can keep people alive for prolonged periods of time, oftentimes with medical intervention. So really, this question here, it can change depending on a diagnosis and depending on what stage of life you're in. Um, Healthy individuals may say, yes, I want them to try everything because there's nothing wrong with me. But if you go through life and then get a diagnosis, that's a good time to come back and circle back. Is this still what I would want? So two very different pictures of what kind of care can be provided. It also is important to recognize that when you say, I want to stop or hold medical treatment that would prolong my life, it doesn't mean that they're going to deny you care. It just means you don't want that additional layer of medical intervention that would put you in a hospital because of artificial means of keeping you alive. So, questions about the two differences? Feel free, while I'm going to drop things in the chat, we'll be monitoring the chat and feel free to ask questions. So the next part of your document is on artificial nutrition and hydration. Again, this is a personal decision. This is something that you can choose to have depending on your personal preferences. I like to describe what that looks like though, so people understand what they are agreeing to. So my mom, when she found her way to the ICU for the last time, her document said she wanted artificial nutrition and hydration. So the nurse came into the room and said, we're going to try and get you on tube feeding. Mom had Parkinson's, she had heart failure, she had really bad arthritis, and she had some mild dementia. And so she had a bunch of things going on with her, but the reason she wound up in the ICU is because she hadn't had her Parkinson's medication. And without that Parkinson's medication, she couldn't swallow any food, which also left her weak. So it was kind of like a snowball effect. And so the hope was to get her strong enough so that she could take her Parkinson's medications after getting some nutrition in her. So the nurse came into the room, and the way that they do the artificial nutrition and hydration, for the nutrition part, they use a tube that goes up the nose, down the throat, and into the belly. Once it's placed, then they connect that to the artificial nutrition, and that's how the individual is fed. This is a temporary type of artificial nutrition and hydration. For the permanent type, where it's into the belly, that requires surgery. So that is something very different, and this is not really an option at the end of life. So again, the way that they do it is up the nose, down the throat, and into the belly. Mom immediately said, get it out, it hurts. Nurse came back a few hours later, tried it again. She said, get it out, it hurts. I don't want that. So the third time the nurse came in, she told the nurse, get out of here. I do not want that. That hurts, and I am not going to try that. So because of her dementia, I had to ask her, Mom, do you understand what you're agreeing to? And she said, yeah, they're trying to feed me, but that thing is hurt. It hurts. I said, okay, So you're okay with not having that. Do you understand what that means? And she said, yeah, that means I'll die. If I don't get food, eventually I'll die. But that's better than being in pain. I said, okay, you're in charge, mom. Whatever you need. So this is something that you should think about for yourself, because had I been put in the situation to try and decide for her, I don't know that I would have made the same decisions. I don't know that I would have been able to step into that role of being her voice without knowing her wishes. But because she wrote them down, I was there. I knew what she wanted, right? So this is part of the advance directive. It also asks about pain. If you're wanting medications to keep you pain free, if there's any other things that individuals should know about, you can write it in as well. But this is a personal decision. This is something that you need to make for yourself so that your loved ones don't have to guess. I have had people ask me, 30 years ago, I made a decision for my family member, and I'm not sure whether or not I made the right decision. Can you imagine carrying that guilt for 30 years because you didn't know whether you made that decision? This is an opportunity to make sure your loved ones know exactly what you want or what you don't want, and be comfortable being your advocate. So again, in mom's case, she said no, and I let her steer the ship. She was in charge and I was her advocate. The next section, this is the fun part. This is where you get to write in what's important to you. This is where you get to say what makes life meaningful. What would make quality of life unacceptable? If a trial support is wanted, how long would you want? This is where you get to say, hey, if I'm nearing the end of life, I want to be at home, surrounded by my loved ones, or I want to be in my garden. I want to be outdoors. I want to have my pets around me. I want to make sure that if I can take that last walk on the beach, I can do that. Notice this is not about medical decisions. This is talking about what matters most to you. By having that information and knowing what's important to you, your agent, your healthcare power of attorney, can work with your doctor, whether it's the hospitalist or your PCA or your specialist. If they need to make decisions on your behalf, having this information to guide their decisions makes it so much easier to navigate healthcare decision making. So for me, what's important to me is I want to be surrounded by my loved ones. I want to be with my dogs. I want to have cool music playing on the radio. And I want to have somebody cooking bacon in the background because I love the smell of bacon. So with that information, that helps to navigate, right? So how do we ensure that Tutu gets to be in her garden now that there's not a whole lot more that can be medically done, but this is one of the things that are important to her. Then you also have the opportunity to say, hey, stop. You could say, hey, if I get dementia and I don't recognize you, don't worry about giving me cholesterol pills. Just give me the ice cream and let me be happy. This is where you can say, hey, if I get so far along in my disease that I need special help, don't feel bad if you have to ask for it. Giving your loved ones permission so that they don't feel like they're overstepping. Think of it as kind of a love letter to your loved ones, telling them how to take care of you in this information. And then how do you make it legal? Well, it either needs to be notarized or it needs two witnesses. Your witnesses must be over the age of 18. It cannot be the person you've named as your healthcare agent. It cannot be a provider in a facility that you are receiving care from. And one of the witnesses cannot have inheritance rights. I will tell you, sometimes they introduce this document at the strangest of times. The first time I was introduced to an advance directive was 10 minutes before I went in for surgery. They brought me a whole packet of all these things that I should consider. And it was 10 minutes. And I was like, what do I do with this? I haven't even thought about any of this stuff. This is why we want to make sure you have the information so you understand what this really is and why it's so important. Then, what do you do with a completed one? So you want to make copies, either digital or paper copies. And you want to make sure that the person, people that you've named and asked to be your agents have a copy of it, and you give them the opportunity to ask questions so that they feel comfortable using that document as a roadmap should they need to. You also want to make sure that you've given a copy to the health system that you go to, whether it's through your doctor's office or if you're in a health system, that they get a copy into your electronic medical records. You want to tell your loved ones that you've chosen an agent. So know that when the time comes, they don't have to try and figure out who's in charge.
So does Kokua Mao have a process to have this directive on your phone? Oh, that's an interesting, I guess as a storage. Um, or a wallet, or I guess some kind of electronic holding place for your advanced healthcare directive.
For instance, some phone programs have a health place where if you're in an accident or something, the medical professionals can open that, find out what medications you're on, what conditions you have, things like that. Do those programs have a place for an advanced healthcare directive?
So if your provider uses an EMR, that would be where it's stored. So that would be the first place that they're looking for it.
So that's personal medical record, right?
Correct.
Yeah.
Which is why we encourage you to give a copy to your doctor's office as well as to the health system so that they can upload it. So Kaiser patients, if you're a Kaiser patient, you can give it to your doctor or you can send it into their office and they will upload it. So any provider who looks at your records can see it. Same thing for Hawaii Pacific Health and Queens. They all have a place in your electronic medical records so that they can easily bring that up.
It's always a good idea to have one with you if you're going to be admitted to a hospital. It's amazing how many times we get calls from the hospitals and we know they have it in their system, but
and they can't find it.
They can't find it. And so we always have them available for our clients and can shoot it right over.
Well, that's very helpful. Okay. Any questions on the advanced directive or why it's so important? As a caregiver, I'm sure you've come across instances where you may not know what to do for your loved one because you haven't had this conversation, or you think you might know what to do, but you're not sure if that's what they would really want. And maybe they no longer have the decisional capacity to tell you one way or another. That could be a challenge, especially if you haven't had these conversations, which is why we encourage you as caregivers to start doing it for yourselves, because one day you may need care yourself, but it also gives you the language and possibly the opportunity to have that conversation with the person you're caring for. So at least you know what they would want or possibly what they don't want, and you can be their advocate. Gary, you were talking earlier about caring for your parents and how you and your sister both have different opinions of how to do that. But that's exactly why these conversations make so much sense, right? Because this helps to support you with your decision making. So I'm just going to very briefly touch on PULSE because people often confuse the two, and I'm going to try and do it within a short period of time. The provider's orders for life-sustaining treatment. This is the green form. You may have seen it. Maybe your loved one already has one. This is something that is done with your doctor's office. This is not something, if they hand you a document and say, here, let's talk about this next time, that is not doing this conversation justice. This is something that if you want to have a pulse done for your loved one, when you're doing a wellness visit, add on an advanced care planning visit so that they can give you that extra time to talk through this document, because this is a standing medical order. This is something that needs to be signed by a doctor, PA, or an APRN. And it's only intended for a very specific audience. This is people who have chronic illness. They have a serious health condition. Maybe they're medically frail. Maybe they've been to the ER a few times in the last 6 months. This is somebody who maybe does not want CPR at the end of life. Another good way to consider whether that person is a good candidate is, would you be surprised if this patient died within the next year? If you answered yes to any of these things, that would be a good candidate for a pulse. And it's also an opportunity to have that conversation. So to briefly describe the pulse, it has information on the person that you are writing the pulse about. It also has questions on there. If the person has no pulse and is not breathing, do you want us to attempt CPR? Or would you prefer us to allow a natural death? I don't like using the phrase, do not attempt resuscitation. Oftentimes people think that we're withholding something. Rather, would you like us to attempt CPR or would you like us to allow a natural death? Keep in mind that we don't do CPR on people, healthy individuals. This is something that's done at the end of life. Someone has died, they have no pulse. We are trying to resuscitate them. If you take your thumb and your first finger and kind of eyeball 3 inches, 2.5 to 3 inches in a C shape, try and guesstimate between two of those. That's how far we have to push into the chest cavity to be effectively pumping your blood for CPR. 2.5 to 3 inches into the body. You know your loved ones. They might be 98 pounds dripping wet. Would you be comfortable having somebody, a big, strong fireman or EMT guy, coming in and doing 3.5 inches on that person? It is a very violent act. And oftentimes there could be additional concerns such as broken chests, broken ribs, punctured lungs, and the recovery time could be quite longer. The older we are, the less effective CPR is. It is not intended for people who are of an older age. This is actually something that was founded for people who have a sudden cardiac event. And it's not necessarily intended to prolong a senior's life. If you decide that you want CPR, you get full treatment. You are giving full treatment. If you say you do not want them to attempt CPR, you would like them to allow a natural death, you have choices. What are these choices? Well, the first choice is full treatment. If you want CPR, you're going to get full treatment. And if that's what you want, you don't even need a pulse. If you decide that you do not want CPR, then we're looking at one of these three levels of care. The new pulse that just came out in 2023, it has changed the language on it to be a little bit more user-friendly, but it's really talking about what level of care do you want. Full treatment means you're okay with standard medical practice. Selective treatment says you want certain things, but you're going to avoid the ICU. Comfort-focused treatment, they're going to make sure that you're comfortable. They're going to make sure that there's no pain and no suffering. They will give medications as needed or even oxygen, suctioning. They're not going to not provide care, but they are focusing on a different type of care. On this pulse, there is also about artificial nutrition and hydration. We're asking the same questions again, but this is now something that's been documented with a medical practitioner. The new signatures on the pulse, it's going to be the individual if they're still able to. If they are not able to, then the person who is signing is going to have to explain who they are. They are either a legally authorized representative by being named on an advanced healthcare directive. They could be a guardian. They could be an agent designated in the healthcare power of attorney. It could be many different things, but now they're trying to make sure that we know who the person is that is signing on behalf of the individual. So again, the people who can sign to make this document legal are a physician, an APRN, and now physician's assistants. These are the only ones who are able to do this. Patient or their legally authorized representative are signing on their own behalf. And this is also where we determine what the legally authorized representative is and how they fill in the gaps on this picture. The surrogate information is only needed to be completed if, remember we said, if there's nobody named and they have all the loved ones come together and say, loved ones, who's in charge? That is your non-designated surrogate, and that's when that person would need to sign. I'm not going to go too deep into the weeds with designated and non-designated. Just keep in mind a designated surrogate is when mom is sitting in the hospital bed and she says, I want my daughter to be my agent, my surrogate. She's going to make my decisions. that is a designated surrogate. Non-patient designated, that's when that group comes together. So for this document, oftentimes we see it living on the refrigerator. That, bedside cabinet, medicine cabinet. If you have a pulse, you should have an advance directive to go hand in hand with this document, because these go hand in hand. One does not supersede the other unless they are not aligned. If they are not aligned, they're going to go with the most recent document. So if the advance directive is from 2004, but your pulse is from 2023, they're going to look at your pulse, and that's going to be what's guiding them on the care. Quick visual on the differences, and just so you know which one is which. Advance directive, everyone over the age of 18 should have a copy to name your healthcare power of attorney. CPR is not addressed in the advance directive. EMTs cannot honor the advance directive, but they can make sure that that goes with the patient to the hospital. So the pulse, EMTs can honor it. These are actionable orders. These are standing medical right here, right now. What are we going to do? Treatments. Very different. Again, they should be aligned. If they're not aligned, it's usually the advanced directive that needs to be updated because it's old or outdated. So briefly, again, they should be aligned. There should be regularly reviewed just to make sure that the agent is still who you want to be in charge. They're still able to be that person. And conversations should be going on throughout all of these conversations. I mean, all of these, reviewing about the advance directive, reviewing about the pulse. And just a reminder, everyone over the age of 18 needs an advance directive, and not everyone needs a pulse. So if that person is only able to name who their agent is, if they complete it, they get it notarized or witnessed, that is still a valid advance directive. And it is still giving some guidance to providers, to the staff at the ER, so that they know who to call, right? So if that's the least you can do is come up with a name, you get it notarized or witnessed, please go ahead and turn that in so that your health system, your provider knows that you've at least thought that far through. Again, just a reminder, the pulse is not meant for everyone. It is meant for this very specific population. And it likely is somebody you are providing care for. This is just so you get an idea of how the continuum goes. At age 18, we should be completing the advance directive, reviewing it, coming back to it every so often, maybe when there's a wedding, a birth, moving, a divorce, coming back to it and just making sure that it's still up to date with the people that you are trusting. I'm going to speed through here, but we want to make sure folks recognize PULSE is more than just a form. It is really an opportunity to increase awareness, different courses of action. It gives you an opportunity to start thinking about it, thinking about palliative care and how that could support someone with serious illness. Early hospice, if the person is heading towards the end of life, let's get hospice in early. We want to change that question of what's the matter with me to what matters to me. And I'm going to pause there. Do you guys have questions on the PULSE or any of that?
Well, this is a good slide to spend some time with, and also to direct everybody on the call to the Kokua Mau website. I was speaking with Hope before we started the call. They just have a tremendous amount of resources, documents, videos, conversations. So please check out kokuamau.org.